So I've been hearing a little bit from from Michelle and from Heather telling me that the group's fairly new, that you're all fairly new to practice nursing. Anybody been in practice nursing more than a year? Yep. Okay. Yep. More than 2 years? Okay. Good. All right. Okay. So has anybody been involved in the accreditation process? Yeah. Good. Terrific. In general practice or in other areas? So maybe in general practice, in both? Yeah, because there's accreditation in the acute sector, there's accreditation in aged care, and there's accreditation in general practice. Good thing about accreditation in general practice is it's not compulsory. It's not as hard as aged care. I did accreditation in aged care twice, and that was really hard. It's a lot easier. So that's my background with accreditation. We've had 2 rounds of accreditation in our practice since I've been there in 2009. So today what we're going to be looking at is the purpose and process of accreditation, the standards for general practice, and we're going to look at a couple of the standards. We won't have time to go through all of them. We're just going to have a look at a couple of the newer ones. And look at the role of the RN, the PN, the practice nurse in accreditation. So, a bit about the history of the standards. So, the Royal Australian College of General Practitioners created some standards in the 1990s. And standards are best practice. So it's what to aim for. So we have standards for lots of things. Can anybody give me some examples of standards that they've heard of? Wound care standards, yes. Infection control standards, yep. Sorry? Yes, computer and technology standards, yep. Sorry? Access, yep. Privacy standards, yeah. What about your nursing your competency standards? Yep. So there's a lot of different standards. And they help achieve uniform service levels, better health outcomes, but all practices have different ways of adapting the standards to their practices, because all practices are different. And so it gives us a nice umbrella to look at. So the 1990s, the RACGP developed the standards, and they've been changed several times, and we're up to the 4th edition standards at the moment. So reasons for accreditation against the standards. As I said before, it's to get a high level of quality in your practice. The public recognise that the practice has been accredited. We'll give you signs, you can put the logos on your front window, on your websites, on your newsletters, and then the patients have confidence that they're going to somewhere that the practice cares about how they look after you and do things at high quality. Certain government funding called PIP, Practice Incentive Program. Practices get money if they're accredited. And if they do certain things. So there's practice incentive payments for how many diabetic cycles of care you do, so looking after your diabetics, how many pap smears you do as a practice. And you can only get those incentives from the government if you're accredited. You can only get the practice nurse incentive payments if you're accredited. So there's a big push for practices to be accredited at the moment so that they can get the funding for practice nurses. It reduces medical legal insurance premiums, and healthcare professionals would want to work in an accredited practice. Okay, so these are the standards. Lovely tome. You can get them online, or if you're one of the practice's GPs or a member of RACGP, they can order them. Actually, I think you get a non-member price, so you can order them yourself, but they just cost more if you want a hard copy. But they're easily navigated online. but I still like a hard copy. It's good to scribble in. So how are they structured? They've got 5 sections, and they talk about practice services. So that's how patients can access the practice information, health promotion, diagnosis, coordination of care, things like that, patient records. And then there's the rights and needs of patients. And that's collaborating with patients, making sure that they have a say in their healthcare. Safety, quality improvement and education. Practice management, so that's practice systems and management of health information. How do we store those files? How long do we store them for? Are they paper? Are they computer? And physical factors, so do we have access for our disabled patients? Do we have car parking? Do we have privacy in the waiting room? Things like that. The standards are put into criteria, explanation and indicators. So you have the standard and then you have some criterion underneath it. The indicators are what sort of shows that you've reached the standard. Some of the indicators are mandatory and some of them aren't. If they have a little triangle next to them, that means they're mandatory. So when you're looking through the book, you can see the little triangles. And that, they call that flagged, if it has a little triangle next to it. The focus of the 4th edition standards is on patient safety and quality, and this reflects what the Australian government's been working on as well. And the 4 new criterion that they've put in the new standards are clinical governance, clinical handover, patient ID, and medication. And if you've been working in the acute section, you know that they've been talking about that sort of thing as well. Patient handover, patient ID, getting the right patient at the right time. Medications, we didn't used to have that in the standards before, and now we have to look at where our medications come from, how we store them, what the legislative requirements of each state is, that we give our patients information about the medication that we're giving them, that we, if we have any samples in the practice, that they're actually labelled when they're given to the patient with stickers by the doctor, just like you do in the pharmacy, name of drug, how often it's taken, all that sort of stuff. We should be doing that. And it should be written in the notes that they've been given the sample. We should be keeping tracks of what samples come in and what go out of the practice as well, which is very hard, especially when the doctors keep the samples in a bag, in a drawer, in a cupboard. You know, even just checking the expiry dates can be really difficult. But that they're really tightening up on medication management in general practice. So that includes vaccines, vaccine safety. Yes. They're moving towards keeping a logbook of what samples come into the practice and what go out, what get destroyed. So, tick off that it's been expired. Yeah. So we have to work out systems. Yeah. That's only a new thing, and I think most practices are just working towards that at the moment, and nobody's worked out a really good answer of how to do that. But I think the way to start, though, is making sure that if the patient does get a sample medication, that it's been labelled correctly, that they're getting consumer medication information sheet about it, and it's documented in the notes that they've been given that. Yeah, I think it's going to be more difficult to get samples in. I have noticed lately, though, that the samples we are getting now are mailed to us and we get a list. So I think probably if you just kept that list and then, you know, and that was your entry point. I'm not sure about the exit point.
But there's a lot of wastage going on as well, and you wonder why in third world countries they let it run out for a year, beyond a year, still using it.
That's right.
Throwing it out.
That's right. And maybe we'll stop that wastage of samples. I know we had a cupboard. When I first started in general practice, I looked at the cupboard and I cleaned it out. It was just boxes and boxes and boxes that was wasted. Yeah. So maybe it's a good thing, but we're all, that's something to work towards. And we're going to talk a bit more about some of these standards today. A bit more. So the process of accreditation. So you need to be registered with either one or two companies. They're not-for-profit companies. One's AGPEL and the other one's called GPA, General Practice Accreditation. So you need to register with them and, of course, pay money. They both have really good websites with a lot of tools. AGPEL has free education modules, which if you're a member of AGPAL and you can get your password from your practice, go on and it links you to Think GP website, and I think there's 4 or 5 modules on there about accreditation, and it goes through infection control, quality improvement, and a few others. They're very good. The modules are quality improvement, reusable equipment, infection control, practice management, and practice services. So both of those companies have policies and procedures, templates, information sheets, a whole lot of resources to help you. So you have, once you've joined up, or if you're re-accrediting, you have 12 months to prepare for the survey. And you do an analysis. So you do your own analysis of the standards for your practice. On AGPAL, they have a lovely web-based tool that you just go through. It links you up to the standard. You can read it. You can say, this is what we do. Yes, we comply. You write your procedure of what you actually do, and then you move forward to the next one. And it's a good learning process because you actually get to write down what actually happens in the practice. Then after that, you send that in, and then you book in for a surveyor to come and visit your practice. And it's usually 2 or 3, and they're our peers. So it's practice nurses, practice managers, GPs that come and do the survey. They're usually there for the day. They'll have meetings and talk to you, different staff. They usually give you a list of the sorts of things that they want to look at and the questions that they want to ask. Always good to give them some sandwiches and a nice cup of coffee and things. They then submit that report to AGPAL or GPA, and a committee there decides whether you've passed or not. And there's actually no pass or fail. What they do is if they don't think you've come up to the standards, they send back recommendations and you just adjust what you need to do. If you have to do a lot of recommendations, you may have to pay a bit more money to be reassessed. So it's good to sort of get most of it done the first time. That's it for that. Okay, let's have a look at some of the criteria in the standards. So clinical handover. So this is something that happens all over the healthcare system. Can you think of opportunities for clinical handover in general practice? Sorry?
When you've triaged.
Yep. So you've triaged and you're telling the GP this is what happened. Yep. When else? Doctor to nurse, yes. Yep. Receptionist, yep. To the allied health, yep. Carers, yep. Yep. What about when ambulance come in? You need to be able to hand over to the ambulance. Referral letters are a type of handover, when the doctors write a referral letter. It could be on the telephone, it could be electronic, it could be written, or it can be face-to-face. So there's a whole lot of really good work to do with clinical handover, and they've put out a tool. You may have already come across it, the ISBAR tool. Yep. So identify. So the I is for identify yourself and your role, and your patient with 3 identifiers. We'll talk about that in a minute. Situation, so what's going on with the patient, why you're concerned. Background, what's the clinical context or background. Assessment, what do you think the problem is? And then your recommendation, what do you think? And have a shared understanding with the person that you're handing over to, who's the responsibility next, who's going to do what. So with clinical handover, say referral letters, you need to make sure that you've got the 3 identifiers for the patient on there, that their medication list is up to date. You want to make sure that that handover is correct. Okay. There's actually an ISBAR app. Of course, there's an app for everything. And it goes through different situations. It does the acute ISBAR, it does more of a primary care one, and it goes through, it's got a whole lot of different sort of situations, obstetrics, and the sorts of things that you might ask or might talk about. And it gives a nice structured way, so you're not sort of floundering a bit, saying, oh, this is, what's her name, I've forgotten, she's the one with the toe, she's come in, and I think she needs to be seen. It gives it a bit more structure. Okay. Safety and quality. So there's a few criterion under this standard, and we'll talk about a few of these ones in a bit more detail. So quality improvement activities, clinical risk management systems, so process for identifying, monitoring and reporting near misses, clinical governance and patient identification. So quality improvement activities. This is a real buzzword in everything now, in business, in health, and it's just so that you're continually looking at what you're doing and seeing whether there might be a better way or a more streamlined way to do things. And the way that we can do that is look at clinical auditing. We can look at patient feedback. So an example for the patient feedback, we did our patient feedback, and twice we did it, and both times it came back that our patients would like us to be open 24 hours a day. Sorry, can't do that. But so what we realised was that they didn't know about our after-hours service. So we've been really promoting that now. We've got a whole lot of flyers and magnets. All the letters we send out, we put in something about it, so that they knew that even though we weren't there, the after-hours deputised service would see them, they'd send us a letter, and we'd still know what was going on. And so it was a stopgap in between them not being able to see us. So that was a quality improvement, and we just had to write that down, and it was something that we could use in accreditation to say that we'd made an improvement. And it was the decisions were based on practice data, on data that the patient had given us. So in some of the other areas of quality improvement could be improving your recall and reminder systems, participation in the improvement foundation initiatives, collaboratives. Has anybody heard of those? Anyone been involved in collaboratives? That's a more of a structured way of doing some improvements. We just finished one with COPD patients where we wanted to make sure that all our COPD patients, chronic obstructive pulmonary disease patients, had their flu vax up to date, their pneumococcal up to date, they all had a care plan, they'd all had spirometry. And because we only had 52 of them, it was something that we could do. And that was done with the Improvement Foundation, and we could benchmark against other practices and see how they were doing. So it was a little bit of competition for the doctors too.
Just on with text messaging.
Sorry?
Text messaging, which is the best way of contacting the patient.
What do you mean?
Just done a quality improvement with text messaging.
Oh, have you? Yeah.
Which is the best way of recalling, getting patients back, cheap versus price, time.
Yep. And what did you find for your practice? What was...
The SMS
is the best, yeah. And people...
So you just track it.
Yep.
In terms of documenting all of it, outweigh everything.
Yeah.
And we've done that, been doing that, it's been a 2 years study.
That's wonderful. Yeah, and I think patients are expecting that sort of technology now. We get it from our hairdressers, we get it from other Yep. And they're expecting that reminder, if you can't make it, please call as well.
So we've done that like as in bringing like all different techniques.
Yep. Yeah. I noticed too, we have our new patient form. The doctors look at it and then it comes to the nurses so that we can just make sure that all the data's been put in properly. And we have a tick box, how would you like to be contacted? And it's always 99% of our new patients, it's mobile phone.
Lots of people lose their phones or change numbers, or that's the only problem that we did find.
Yeah.
There's a high rate of people not paying attention, changing the numbers, and but still was the best.
The better way. Yeah, great improvement. Hope you've documented that. Yep, and then revisited it. Yep, good. And clinical risk management systems. So that's monitoring near misses, deviations from standard practice. So near miss is something that didn't do any harm, but it could have done harm. We had a near miss reporting recently. We had a new doctor come, and normally the nurses do the immunisations, but this time she did it, and she grabbed the Infrax Hexa, and she didn't take both pieces. It was in one of those multi-packs. So she just took the syringe part and not the Haemophilus influenza part, and so she just gave that. So the child just had to be vaccinated then against Hib, but so it didn't. It did detriment. They did have to come back in and get another injection, but it was a near miss. We realised that in orientation we had to make sure that the doctors knew about that sort of thing and that it was highlighted. That was a bit of a risk, those multi-packs.
And would it be recorded as a medication error? Is that something that
Yeah.
we do in general practice?
Yeah, so you should have some sort of log where you have an adverse event. So it can be an adverse event with staff, with patient, with that sort of thing, and it should be followed through, just like in any other area of health where you look at it and you decide, take it to a meeting, discuss it, make sure everybody knows about it, and then try and improve on it.
They actually like to see those things in accreditation.
They do, I know, and it's really hard, I know the first accreditation we went through, they hadn't documented any, and so at the last minute they're trying to think, what near misses did we have, and so they're writing them up, But when those happen, it's really important to grab hold of them and think, well, it didn't happen this time, but something really disastrous might happen next time. So that's it. Clinical governance. This is a bit of a buzzword at the moment. And all this means is that we're having a bit more accountability for our actions and improving in quality care. So there's a big push for people being accountable for different roles in general practice. So you have somebody that's in charge of infection control, somebody that's in charge of complaints, somebody that's in charge of cleaning, somebody that's in charge of computers, someone's in charge of vaccines. There's one more, I can't think of it. But they're, improvements, of course, yeah. It's written into their job descriptions and they're held accountable for it. When their performance reviews, that sort of thing, they say, well, what sort of job are you doing? And it's measurable. So that's what clinical governance is. Sorry about that. So it ensures accountability of individuals for the delivery of safe and effective care, because we're still, first do no harm, even though we want to improve things. So, patient ID. This was new in the new standards, and it's in line with across all the health areas, and it's making sure that you have the right patient. And this has been a bit contentious in general practice because the reception staff feel that if they know the patient and they're familiar with the patient, why do they have to keep asking? But I know if you've been to other health providers, pathology, they always ask you for your 3 identifiers. I know when I went and had an ultrasound, it was actually in their software for their ultrasound machine that they had to ask me who I was before the machine would turn on. So it's becoming the normal practice, and it does save a lot of mistakes. So the 3 approved patient identifiers are patient name, date of birth, gender that the patient identifies with, address, and patient record number if they have one. Not Medicare number. That's not a approved patient identifier. And you can't, if you say to a patient, is your name Jan? And they go, oh yes. They may be dementia, they may be hard of hearing. You need them to say it themselves. So you need to say to them, could you tell me your date of birth? Can you tell me your full name? What's your current address? And it actually, for the reception staff, it will update a lot of addresses and things that aren't up to date. And these patient identification, as I said before, is very important also with your referral letters and any other correspondence that you do about the patient. We had quite a few near misses with patient ID with our double patients, and so now we actively look at our practice data and try and find all our patients with the same name and label their charts or their electronic records with this patient. There is another patient with the same name. Please check, double check. There's nothing worse than you think you're seeing a 45-year-old and a 75-year-old walks in the door. You've aged. It's the father and son, both with the same name. Yeah. Has anybody had experience with that? With the wrong patient? Yeah.
Especially at the booking end, like at first they would just sort of picked on the name. It was very close and just uploaded the wrong patient entirely into the bookings.
Yeah. And you say to them,
you're halfway through a care plan, unless you actually.
Yeah.
That's why it's very important.
Yeah, it is.
Quite a way through a care plan, just assuming, but things started to not add up.
Yeah.
And then I went,
Yep.
just a
Yeah. Yeah. Have you got any allergies? No. Oh, there's a whole long list here. Yeah. And certainly for a procedure, we should be identifying our patients. So the identifying isn't just at the reception; it's when you see them, when the GP sees them. So at every stage, it should be going on. Equipment for comprehensive care. So under this standard, there's 2 criterion. There's practice equipment and doctor's bag. And since the last standards, there's now we need to have a height adjustable bed. It doesn't have to be electronic, but it needs to be height adjustable. We need tongue depressors in the doctor's bag, as well as surgical masks. And the equipment needs to be maintained. So not just a register, we need to make sure that the ECG's been checked every year, that the batteries are changed on the thermometer on the vaccine fridge every 6 months, things like that. And it needs to be documented. Air conditioning, who cleans the vents in the air conditioning? Is it done often, or are we blowing dust all over our wounds? Are the carpets steam cleaned regularly? Are the chairs wiped down every morning? What's your routine for your maintenance of equipment?
People will ever be required to have a defibrillator?
It is, what they say is when it's written in there without a mandatory, but it's written, it usually means you're trying to be working towards it. So it's the same with the pulse oximeter. They're recommending that it's good for a practice. I mean, the defib is in part of the ABCD. And certainly some practices get a lot of chest pains and the acute sort of centres, and they probably do need them.
Well, you see them in clubs and schools are really getting them, you know, all of these community places.
Yeah, why isn't there one? And people would expect if they turn up to a GP to be having that treatment. Yeah. So I think.
That's why I recommend that, because 2 weeks ago we had a death in the practice, there was someone dying in the waiting room. And it's pretty frightening. It was a pretty big shake-up for all our emergency systems. But this gentleman literally just came in, he sat down, he'd been in 2 days before, he'd had some ongoing symptoms that weren't necessarily cardiac, it wasn't allergic to cardiac, it sort of came up more more like a stomach issue, and there was things like gastric pain. He did end up having an aortic rupture in the practice. He just went bent over like this, and one of the nurses came and sort of walked by and said, "Are you all right?" And he just went, he was blue, black, he was dead. And pretty frightening. The point is though that there was, you have to work on it until it's you have to still get
I don't know where I saw it, but it was fairly recent, and it said that, and maybe it was off health because that's my background. There was the issue of defibrillator was the owner of the company, the practice, has to do a risk assessment, and in that, if there's a chance that it's a possibility, then they have to, of course, do the matrix, and that is where the defibrillator comes in, because for us it is a high-risk environment of it occurring, and of course the seriousness escalates the pyramid more. But the owner is legally liable for not doing the duty of care to the people in that establishment.
That's
and
right.
To the staff, to cleans, anyone else who may suffer.
That's right. Yeah.
And they will get fined. And I find that if I show that to our director, and he was, you know, once they see it as them going to court, it was very quickly procured.
And that's a really good point with the risk assessment, because that's what they're wanting us to work towards, in that every practice is different and you need to have a look at your risk assessment and see whether it is a high risk, a low risk, and what's the reasoning behind it. Yeah, no, very good point. And I'll need you for my next one, because we talk about risk assessment in there, and look like you've got a good understanding. So at the moment it's up to the practice. There is, I noticed there's another app. There's an app you can get to tell you where your nearest defibrillator is as well. So if you want to know which ones are in your area, they're the public ones. So your equipment register, your maintenance book, should be talking about your servicing intervals, how often you service things, and if you don't know, usually the manufacturer should be able to tell you how often something needs to be looked at.
I just say this has all got to be a physical book, doesn't it, too? Our
No,
practice book, or just on computer?
Well, it depends. It could be on computer, but as long as somebody knows where it is and they're entering in the detail that happens. I mean, you could have it as a calendar, you know, in Outlook or something, where your regular services come up and are highlighted. But you do need to be able to show the accreditors that that's your system, and if that system works for you, that's fine. Yeah, it doesn't matter how you get to that point, but if you've got a system that works, yeah. Yes, I think with the sort of electronic reminder systems and things that we have now, it would be, you know, it's much easier. Okay, so that's probably all for that. Continuity of care. So this is a really big one in accreditation that they always look at and they always ask the GPs about, because it's a high risk area. What happens when you have patients that have clinically significant results that need to be recalled back to the practice? What's your system? Everybody's system's different, but it's each practice should have the same system. I know where I worked, we had different doctors doing different things, and that's where problems occur. I can see a few of you nodding your heads. Yeah. So one might use a paper system, one might use the electronic, one uses the receptionist to ring for non-urgent, one rings them themselves. It's a good idea to go and find out what system happens in your practice, and then find out what the gaps are, what could be a problem. So we should all be able to describe the system by which the results come in and are acted upon, and then written about in the notes. Okay. And what happens when patients are on sick, or when doctors are on sick leave, or on holidays? Who's looking after their results for them? That's always a gap. So recalls and reminders, they're often interchangeable. Recalls are when it's clinically significant and the patient needs to be notified. And that's when, if you try and notify them and they don't answer, you should be trying to ring them 3 times at different times of the day. And if they're still not answering, you need to send them a registered mail. It's up to your practice. I think it says that you should be doing as much as possible to notify that person. I think one of the stories from our practice was they ended up getting, it was a lady with a breast lump that was very suspicious. They ended up getting the police to notify her because they couldn't find her.
Some people don't have homes. They have that problem. And other times, in the software, it's not written like it says doctor notified or didn't notify, but it doesn't give us an option to say that patient refused, because you can ring them so many times and notify, but they're just not wanting.
And maybe that's something you need to have a look at in your practice, is where you do that extra follow-up. Where do you document what's actually happened, so that you have a good circle of documentation. So recall applies to all clinically significant pathology, diagnostic imaging, investigation reports, referrals, correspondence, where for medical, legal reasons you need to ensure the patient sees the doctor. And a reminder is more your preventative health stuff. So it's reminding women that their 2-yearly PAP's due, that they should come in for a 45-year-old health check, that your 4-year-old needs to come for a health check and his vaccinations, things like that. Or their second Hep A, or things like that. There's really good software in your practice systems to do recalls and reminders, but just make sure that you're using the coding and not all the free text, so that it keeps it nice and clean. Does everybody know what I mean by coding? Yeah, so when we're looking at our patient data, we want the computer to, so say we want to search for all our diabetics. The computer can search for the word diabetics, but if it's been typed in with the wrong spelling, it won't recognise it. So any of your drop-down boxes that you highlight, that's your coding. They're the ones that you should be using. You should try not to use any free text in any of those, in your diagnosis, in your reason for visit, in any of those things that gives you an option with a drop-down box. Try and use that. And then there'll always be a little area underneath somewhere where you can put some extra information. It's very important, because if you want to know who your population is, or if you're searching for something, at least you'll get proper results. So patient recalls, I think we finished that one. Patient reminders, we talked about that. And if they don't answer the reminder letter for a reminder, there's no follow-up. We don't have to keep chasing them. There's no legal obligation to send out reminders for pap smears and things. It's just good practice.
I don't know if everyone has their practice details on the outside of the envelope, but I know practice that on their envelopes put, this contains important health information. So if there was a change of address, they were more likely to get the letter back. So then they could actually prove that they tried to get to the patient. Whereas if you just get a letter in your mailbox and the person's moved out 5 years ago, you just think, I can't be bothered. You see that you're more likely to return it to the sender. So make sure that you do have your details on those envelopes, the letters to go back, because then there's proof that we have tried to contact them as well.
That's a very good point. Yeah, very good point.
Could that maybe also be possibly a confidentiality issue? Because it might be, say, a 21-year-old in the family and they have agreed only to unidentified letters.
Like I'm just thinking of right now, vaccination rather than anything else, it's mainly for that, but yeah.
I think our accredited discipline that's on them too identifiable. If they communicating with me on the phone saying, yeah, I know, it's weird, isn't it? But they get really close about you saying that you're from the voluntary medical practice. And so to say it's what is your name and your number.
Okay, because of privacy issues. It's very difficult, isn't it?
Very difficult.
Sexual health, when they have to do contact, they actually say it's community health or it's public health. So they never identify themselves in case it's not the person.
Yeah. Very good. So for your recall policy and procedure, well, we just talked about making sure your database is up to date with your addresses and things, if possible, and also getting them to identify what their main contact is. Is it better by mail? Is it better by phone? Staff training, making sure that the procedure for recalls is written down somewhere so that if somebody new comes in, they can look at it and they know exactly how that's done. And that you've got the letters, the templates and things in your practice software. So, role of the practice nurse. Nurses are really well placed to be doing all this sort of stuff because we are the go-between the GPs and the reception staff and the allied health. We can sort of move in all different areas of the general practice scene, and so we're really good linkages to be doing this sort of improvement work and this sort of accreditation work. And we've only touched on a few of the little areas today. There's a whole lot more. So you can actively contribute to policies and procedures. So a policy is what you're attaining to, and the procedure is what you actually do. Implement changes as needed to ensure compliance with these standards. Assist the practice with self-assessment. Assist with resource development, and do your plan, do, study, act. But the role quite often depends on the practice, how much input you get into doing accreditation. But if you're interested in one area, try and develop that, have a look at the standards and see what sort of improvements in that one area that you could do. So your plan, do, study, act. Is everybody familiar with this? It's your basis for continuous improvement. So, say we noticed in our software that we hardly have anybody marked down as smokers or ex-smokers, and we want to send out letters to find out if they want to come in for spirometry, but none of them are marked. So, what's our plan? Who are we going to talk to about the plan? What will we do? What do we think the outcomes will be? So maybe we're going to talk with all the practice staff and say, how can we increase targeting the smoking status on our patients? we decided to put little stickers on all the computers so that just for a few weeks, every patient that came in, the doctor would remember to ask them their smoking status. So we did that, we studied it, it didn't work very well. They were too busy and they didn't do it. So we had to think of something else. So that's studying, analysing whether it worked or not, and then re-looking at it again. And then acting on that information. And then it goes back around again. Planning, maybe another part of that. Well, now we've got all the smoking status, now let's plan to how we get in these patients, these ex-smokers and smokers, to test their lungs. So that's it's good idea if you're doing these to keep them very small. Just do little things at a time. Has anybody used this process in their practice or in other areas? Yeah. You'll find it in most of health, in a lot of business. This is the way to think of improvements and to build on them. So the key messages today: nurses are leaders and play a pivotal role in accreditation. Accreditation is about quality improvement, that plan, do, study, act cycle, opportunity to show practice nurses that we're leaders, and it's an ongoing, continually evolving process. There's some useful resources. The Royal Australian College of General Practitioners, they have a poster, actually this one's from AGPAL, I think. Why do we keep asking for your name? You can get it in an A3 or an A4. And they also have 10 tips for safer healthcare. Actually, I'll pass these around. Look at them. Then there's the websites for AGPAL, GPA, and the Australian Commission on Safety and Quality in Healthcare, where you'll find all your things about ISBAR and patient ID. Feedback, when we do accreditation feedback, we need to do it with accredited companies now, and they're the two companies that are doing the feedback, patient feedback. There's also a feedback tool just for practice nurses called the PESS, and it's the Patient Enablement and Satisfaction Survey. And that's another survey that practice nurses can do to see how their patients are liking their care. So here's some ongoing learning for you. Find out when your practice is due for accreditation. Find out where the standards are kept in your practice. Do you have a copy? Are they downloaded on the desktops? Find the report from the past accreditation cycle. It should be there somewhere, and it'll tell you what was failed and what had to be improved and what you did well on. Find out where the policy and procedure manual is in your practice and have a look at it and see if it's current. Quite often they're very funny because they're just nothing to do with what you actually do. Or they might be just downloaded straight from the website and not even changed to your practice. So they're a lot of fun looking at those. But you may have one that's really up to date and doing exactly what everybody's doing, saying what everyone's doing.